Dr. Bharati Kashyap, Dr. Merlin Paul, Rachel Joseph. Is everybody there? So I think without wasting time, let's start with our session. Dr. Tani Natung is there. Yeah. So are you taking the first one, Abhijit?
Yeah.
Okay.
So this is like pause, breathe, breathe and go. So it was supposed to be an entire session. I can't probably take you through the entire topics in this. So we are just going to tackle PCR and different ways of managing the PCR at different stages during the surgery. Now here I have already made all the pieces and suddenly I find a rent there. So that's where you take a pause, take a deep breath, and now you decide what is to be done. But one thing you will never let go is your foot switch. Form the chamber with a dispersive viscoelastic, and then get all the pieces into the area in which the break is not there. So you're going to just bunch it up over that area, and either that or take it into the anterior chamber. And you can continue with slow mo phaco and complete the case. So with a formed vitreous, what you have to understand is the vitreous acts as a scaffold and in fact doesn't allow your pieces to go down. The only thing when it takes it down is when you increase the turbulence in the chamber. So here I have decreased my aspiration to 20 instead of 26, and you just continue with the phaco and the pieces go on coming to you and the vitreous strands do not come into the phaco tip. After that you can stain it with triamcinolone and do a vitrectomy. Now this patient was posted for a toric IOL. So we were assessing how much of support do we have in the back, because it's a hydrophobic toric IOL. Anyways, I wouldn't want to put any IOL in the sulcus, which is a single piece. So here I'm using the vitrectomy cutter in the IA cut mode, which is really helpful. So you can aspirate and eat the cortex at the same time. Now you can see half of the PC is gone. So now this is not an ideal scenario wherein I can put in the toric IOL. So definitely I'm going to put in a 3-piece IOL out here in the sulcus and then do a optic capture posteriorly through the capsule. Now case number 2 is a tear which happens during the eye, and there you have it. Again the same principles. You're not going to let the chamber shallow down. You can see the flap is moving, so you can actually use a double-handed technique in which you lift up the flap with a Sinskey hook and use a microrhexis forceps from the side port to do a CCC and put in a toric IOL in the bag, and it works very well and you don't have a vitreous loss because you picked up the rent at the right time. This is case number 3 wherein it just gave way, the PC, and I have a huge triangular flap out there now. I try to do a PCCC out here, but it's gone too much to the periphery, so there's no point in trying to do a PCCC. But this patient is for a toric IOL. So here I see which axis it is in, and I have plenty of support in that axis. So what I do is I gently nudge the haptics into the bag where the capsule is intact, and then rotate it reverse because the other side haptic is not in. It's easy to for you to rotate back into position the other way around. That's anti-clockwise. And then slowly nudge the other haptic also inside the bag, and then do a anterior optic capture for this patient. So here the main thing is your exercise should be somewhere around 5 millimeters when you're operating. So if you're aiming at 5 millimeter always, you can always salvage these kind of cases. Now this is a patient in whom I had already done a toric IOL in one eye, and I thought I would get away because even in the previous eye, I had not used a pupil expander. So I had just finished off all the chops and the pieces, and I was looking at the last piece out here, and suddenly I see that the things are not too well. But I'm not able to assess the posterior capsule because the glow is bad, because the pupil is small, but there are nuclear fragments in the bag. So as in the first case, I get the pieces out into the chamber, go to a slow-mo, I'm at aspiration of 20, IOP of 26, and then finish off the aspiration of all the pieces. But at this stage, I feel that I'm not having good visibility. So this is the time I use a Malugan out here to expand the pupil and assess my damage. So Malugan can be used at, or any, for that matter, any pupil expander can be used at any stage, and you should be open to it and just use it so that it makes the life easy. And again, I'm using the vitrectomy cutter out here to do the vitrectomy as well as the eye cut mode for the cortical aspiration. But as you see, the rexus is the PC tear is quite a bit. It's more than half the PC torn. So again, in this case, I choose to put a 3-piece IOL instead of the toric IOL and put it in the sulcus, and then do a posterior optic capture for the optic. Thank you.
Yeah, very well demonstration of all the cases. Just one question for you.
Yep.
You had two cases where it was you had planned toric IL. So how did you manage the astigmatism later on?
So fortunately, both the patients were T3 model, so it was a
It was not
0.75 to 1 diopter.
Suppose
So
it was a T8 or
a
T9.
T8 or a thing, we could have later on tackled it with a LASIK or any other treatment.
Sulcoflex, poor LASIK.
Sulcoflex, if I've already a IOL in the sulcus, over that would not be such a great idea.
Thank you.
Thank you very much for the talk, doctor. I now call upon our second speaker for this session, and the topic is optimizing outcomes of trifocal IOL, Dr. Tani Natam. Welcome you.
What is this? I had done in this review. Good morning, everyone, respected chairpersons and all other speakers. My talk is on optimizing outcomes of trifocal IOLs. My name is pronounced as Dr. Tani Natum, and I am from Northeastern Indira Gandhi Regional Institute of Health and Medical Sciences, Shillong. So for optimizing outcomes, we have to have certain considerations, which are preoperative considerations and surgical considerations. In preoperative considerations, we should have proper patient selection, precise biometry, correct IOL power calculations, other diagnostics, and patient counseling. So in selection, we should look into the patient's lifestyle and personality, like occupation, hobbies, daily activities. Patient's personality, like there should not be any unrealistic expectations or type A personality. And we should look into the patient's needs and preferences for distance, intermediate, and near work. Then we should rule out certain ocular conditions in the patient, like corneal and external eye diseases, like pterygium or blepharitis. We should be treated beforehand. And if there is astigmatism or more than 0.75 diopter, better to put trifocal toric IOLs. And dry eye should be managed properly, because abnormal refractive surface causes will cause dysphotopsia. And also we should rule out previous refractive surgery, because there is loss of contrast sensitivity, and zonular weakness, because it will cause IOL decentration or tilt, leading to dysphotopsia. We should also rule out pupillary abnormalities, because good pupillary centration of IOL is required for good outcome. And retinal and optic nerve pathologies like glaucoma and macular disease are also associated with decreased contrast sensitivity. And we should look into the angle alpha and kappa, because temporal decentration will cause photic phenomena. Coming to the biometry, precise biometry is very important, and optical biometers are recommended. Immersion biometers can be used, but contact biometers are not recommended. Do keratometry before tonometry, PECI, or A scan. A patient wearing contact lens should be advised to remove these 1 or 2 weeks before taking care readings. Make sure the eye is well centered. Coming to IOL power calculations, newer IOL formulae are recommended, like Barrett, Universal 2, or Hill RBF. These are freely available online in APCRS websites. These are the links that is freely available. And if we feed the data into this Barrett Universal 2, we'll get the power, correct power. And also for Barrett toric calculator, if we feed the data, we'll get the proper axis and the correct power. So we should target emmetropia, and if there is more than 2 diopter difference in the IOL power between two eyes, we should recheck. We should also be mindful of angle kappa, which is the angular distance between the pupillary axis and visual axis. If these are large, this can lead to glare and halos. There is some indirect way of detecting the total eye aberrations. So in IOL master, if you see in the white to white area, if px and py magnitude should be less than 0.6 mm. If it is more than that, there's likely to have more peripheral aberrations. Similarly in Leinster, so we should avoid in such cases. Similarly in standard K values, if K value is more than 0.2 diopters, this may give us irregular astigmatism and lead to refractive surprise, so we should be mindful of this one. Similarly, angle alpha is the radial distance between the limbus and the visual axis. This can be detected by eye trace, which everyone may not have. But coming to other diagnostics, retinal OCT is very important, because some subtle conditions of retina may not be picked up by clinical examinations like ERM, VRT, or RP changes even by retinal specialists. And uh, patient counseling is very important. We have to give some extra chair time for these patients, give enough time to patients to decide, and explain the limitations of the technology, under promise and over deliver, because this is a one time opportunity to change the lifestyle of a patient. And we must involve other key decision makers in the family. So before surgery, who are the good candidates? So those who are free from ocular comorbidities, those who want to be less dependent on spectacles, and patients who are well motivated, no undue expectations, and those who are likely to accept some amount of imperfections. So poor candidates are the opposite, those who are having ocular comorbidities, highly critical patients or perfectionists, nighttime drivers, those who have very dense cataracts, and weak zonules or pupillary abnormalities. So coming to the surgery per se, we should have a very round and central rhexis, and there should be good overlapping of IOL over the rhexis. Otherwise, there may be tilt or decentration. So we should make sure that the rhexis is very circular and central, like this one. So as far as possible. And in cases of toric IOL, we should make sure that uh, the dots are aligned with the pre-marked axis marking. So here I'll just show a, excuse me, this video is not playing. I'll just show from the directly from the video. इसको play करने दें. Okay. So implantation of trifocal IOL is same as any monofocal IOL. Here we should make sure that we go behind the IOL and remove all the viscoelastics so that there is not much movement or decentration, and the IOP at the end should be optimum so that it is well centered. And similarly for trifocal toric IOL, initial markings are done, and then Rexis SSH should be very circular and well centered as far as possible. Markings are done, axis markings are done, and after good phacoemulsification, we put the toric IOL and remove all the viscoelastics and make sure that the IOL is well centered. Sorry, because of this. Then post-op, we make sure that the IOL is well centered, like even if that in dilated positions. So there are certain limitations, but like residual refractive errors, in such cases we keep a gap between surgeries of 2 eyes of approximately 3 to 4 weeks and see the refractive outcome in one first eye. And if any residual error is there, we can adjust in the second eye. These photopsia like halos and glares are very negligible in the newer trifocal IOLs. Neuroadaptation does take place, and these are minimal compared to bifocal IOLs. So my take-home message is careful patient selection, precise biometry, correct IOL power calculation, proper patient counseling, and good surgery are the keys to success. Few limitations are there but can be overcome easily. These are my references. Thank you very much.
Thank you, Tani. Um, just a quick question here. How do you center the IOL in the visual axis on table?
So we take the help of the microscope, 3 points, and ask the patient to look at those lights and then try to center.
Because I was seeing your video, it was very well centered, and
Yes,
both
yes.
the Purkinje images were overlapping each other. So
Yes,
that's how I would actually center it. So get the both the Purkinje images one over the other, and
Yes,
see
yes.
to it that the central optic is in that
Yes,
zone.
yes, that is the idea. So how we get help is ask the patient to look at the microscope lights. So anyway, thank you very much.
Thank you very much, Doctor. I now call upon Dr. Bharati Kashyap. Do we have Dr. Bharati Kashyap here for the next talk? We have Dr. Sudhir Singh. I welcome you, sir, to speak on SSES in PPC. Do we have Dr. Sandhya Nair here?
वीडियो प्रेजेंटेशन
Close that light.
Dr. Swati Agrawal.
Yesterday struggled so much. This hall had a couple of few lights. Yesterday I had high commitment in this hall. Not a single person could able to see the stage. Today at least.
Can you shut these lights, please?
No, it's not possible.
Not possible.
Yesterday they have only 2 4 lights.
I'll speak. So I want to share my techniques and pearls, what I will learn over the 24 years of my small experience in the cataract surgery. So as we all know, posterior capsule is so first part is the capsular axis. So usually try I usually try capsular axis size between 5 to 6 millimeter. As these cases, posterior polar cataract are usually soft cataracts, and idea behind keeping axis size between 5 to 6 millimeter is when, in case of PCR, you can have fair margin of rim of entry capsule, so you can implant sulcal IOL. So this is around 5 or 6 millimeter capsular axis, and this is the posterior capsule. Then next important is hydro procedures. It may be hydrodissection or hydrodelineation. So this is the most important part for phaco or SICS. When you just separate your nucleus from the cortex or your like epicortex from the capsule, then things are very easy and complications are very less. So in this case, I do uh, hydrodissection in all my posterior polar cataracts along with the hydrodelineation. So then nuclear flotation, prolapse and delivery. This is most important part. You can see this is a you can the term as a manual femto, but it's better than the femto. As your nucleus is already out from the danger zone. When you are doing SICS, then you can take it out with the any or method, or when you are doing the phaco, then repose it back in the bag. Sir, please. So this is nucleus is taken out. Now this is one of other procedure. I'm doing hydro now irrigation aspiration. Again, this is a very important part of any cataract surgery, and most of complications happens here in the posterior capsule. So just see this. This is a case, and I have idea this is going to be other way around. So I use IEA and see now there is something wrong here. So don't worry here. See, this is badly struck, and I keep on aspirating the cortical matter. Well, here is a one trick. After a few seconds, I this is going to be behind. So what I did, I leverage with this irrigation port. See here, this port is going behind the epicortex, and there is no practically no chance of going back. So I've taken out all the plate. As you know, there's already PCR. So this now anterior vitrectomy, very important part. I do with low highest cutting rate of a machine, uh, about a moderate section, and be in the center. And this is not related to this case. This is another case where nucleus had dropped during the phaco. So I want to see that clear as much as better as you can do. Don't be panic. I usually don't use Tramslon because my macros is quite good and visible to me all fat. But sometime when I require, I I can use Tramslon also. It's a good uh, tool and technique. So idea is clear the vitreous as much as you can do. Now I use always PMMA lenses in the sulcus because the PMMA lenses are very stable, and they are when they are implanted in the sulcus, they are fixed like anything. So, and there is what I've seen over the 24 years of my experience, that these are lenses no less uveitis or practically no uveitis as compared to the foldable lenses, 3-piece folded lenses. So for the sulcus implantation, it's a trick. Basically, you have to be your leading haptic should land in the sulcus first, then rotate in the same plane. Now, retro IOL cleanup is very important. What we do many times, that we leave the vitreous and visco behind the lens. So we should never do this. We should do thorough cleanup anteriorly or posteriorly. This is I'm going. I'm doing behind the lens, and irrigation port is just in front of lens. My cutter in the center, and I have no hurry. Then, when there's a nucleus drop, I always suture and suture properly, because your vitreoretinal colleague need a leak-proof tight, uh, tight like entry chamber and all these things. So I usually 2 or 3 sutures, buried suture, and this is not case the first case, but in this case also it was next day vision was the 612 after a drop nucleus drop surgery under. So thank you very much.
Thank you so much for your nice presentation. You have managed the things. But anyway, my question, why you have preferred SICS over the FECO in the pushes polar cataract? Any advantage?
Yeah, because in these cases, if there is a rent, then all the compromise happens. So I know this space is going to be is going to have the PCR. So SICS is all the advantage of the fake, or what we call the femto. So this is just to give the safety to the patient. I prefer I prefer not to give patient like a drop, a nucleus drop, or something like some any other iatrogenic complications.
But you know, the basic principle of managing the pusher polar cataract, you have to maintain the chamber throughout the surgery. This is very important part. So as I think the FECO is much better than the
No, no,
other
no.
size.
You are right. No, no. You are wrong, sir. In this way, just I'm explaining you why you are wrong, because the SICS is low pressure surgery, and FACO is a high pressure surgery. So when there is a thing which is going to drop your nucleus, so this is low parameter surgery, and why you want there's nothing like positive pressure on all those. So
Anyway,
yeah.
this is the maybe the surgeon preferences, but as I feel, you know, in the FECO also, the slow maker FECO facility is there. So always, you know, if you maintain the chamber, this you have already in this case by doing the SICS. What happens once the chamber is shallow? Any moment the VTS will comes and the
No,
posterior
no, no,
polar
no,
lens
no.
will action
Because
completely.
no, 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 no. Just I'm not. I'm not.
Yeah.
So,
Yeah.
no, 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 no,
So you
I
so you can include the infusion from the side.
let me explain. If you raise this point, let me explain, and you should give me the fair chance to explain this, because what is happening in this cataract also, we have taken out nucleus without. There is a thick apinuclear plate adhering to the capsule. So that until that up to that place, there is no chance of vitreous will come out. Okay. Then the second part I've used the IA, bimanual IA, as you used in the FACO. So this is misconception that maintain all that. This is one misconception also, that we should not do the hydrodissections.
okay.
So, the one
So
question.
yeah.
Uh, I saw the management, everything. How many cases have you converted a PPC into a PCCC and put an IOL in the bag using SICS?
Pardon?
Out of all the cases PPCs that you have done,
Yeah.
how many cases have you been able to convert the posterior polar deficit into a PCCC and put an IOL in the back posterior CC?
I do, but I don't have exact data to tell you. But I have in this next be presentation, I'm going to in the that I have different cases also. This type of all these cases, I'm documented video proofs. So I use my idea is when rent is small, about 2-3 millimeter, then I use the IOL in the bag. When lens is more than 3-4 millimeter and bag is not stable, then I use the sulcus.
Okay, thank you, Dr. Sudhir. Would like to just add few points.
No.
Yeah, one more point I just wanted to add
Yeah.
is not all PPCs will have a posterocapsular ring. So if you had done an anti-segment OCT, if you have seen a rent, even then we have methods to manage with a phaco also.
No. That is a one modality to phaco is a modality to manage the nucleus only. In SICF, you have the also the you can minimize the 0.75 millimeter or 0.75 diopter of astigmatism. So phaco is just a modality to manage the nucleus, nothing else. So this is our mindset because basically when we do, but in as I case, my previous speaker, I forget the name, but he have used the you used for the toric and those are all the compromising things and all that. So I don't want my patient to be compromised. My I want the patient to give the hysterectomy the next day. So that is the idea. And as I give scientifically proven all these things. Okay.
Thank you very much, Dr. Sudhir.
Yeah. Yeah, again, this was deliberate. There's so many things which are not in, we do not put in the publications. Idea is to hydrate bitters is not a problem. When you are going to do the vitrectomy, so my vitrector was ready. So this was deliberate not to sunk in that piece of cortex in the vitreous. So in what we do in the 3/4 part planar vitrectomy, what we do? We deliberately hydrate the vitreous, then do the vitrectomy. So all these things are the misconceptions which are not published. Okay, so
Is Dr. Bharti Kashyap? Thank you, Sudhir. Let's get to the next speaker in view of time. Is Dr. Bharti Kashyap here? Dr. Sandhya Nair?
A very good morning to all. Now, optimizing cataract surgery outcome through biometry, a practical approach. Now, Dr. Warren Hill, in his data entry from over more than 260,000 eyes, has shown that only 1% of surgeons achieved an accuracy of a target refraction of within 0.5 diopter in 92% of eyes, and the majority of surgeons attained this in around 78% of cases only. So with newer methods, today we can achieve around 90% of accuracy of within 0.5 diopter of target refraction in 90% of patients. Now, Norby et al. In 2008 studied the source of error in the refractive outcome of cataract surgery and found that the preoperative estimation of the accuracy of the estimation of effective lens position was the most common source of error. followed by postoperative refraction and axial length measurement. But now things have changed. Axial length measurement is no longer a limiting factor because of the superb accuracy of optical biometers, and effective lens position is still the commonest source of error. Getting accurate keratometry is another problem because we need to validate the data, you have to optimize the ocular surface, and you should look carefully at the Myers for their clarity. Now, getting good keratometry measurements is possible with optical biometers, but in unusual eyes, as in case of post-refractive eyes and in steep and flat corneas, this may be supplemented with topography. Now, we need to validate the measurements of optical biometers, and then if any of the measurement is not good, we need to measure it again, and this will save us from a lots of trouble. Now, having taken good measurement, we'll move on to IOL power calculation formulas. Dr. Douglas Koch has classified formulas based on their method of derivation and the data they use for these, and these are obsolete. And Virgin's formulas, they are based on Gaussian optics, and Barrett Universal 2 is based on 5 variables, that is axial length, keratometry, anterior chamber depth, lens thickness, and white to white. And Holiday 2, in addition to these, uses preoperative refraction and age of the patient. Now, Olsen formula, which is a ray tracing formula, it takes into account the entire optical aberrations of the eye, including that of the cornea. It also takes into account the shape of the IOL and the sphericity of its anterior and posterior surface. Now, Hill-RBF formula is an artificial intelligence based formula. It also uses regression analysis of the postoperative refraction of the patient and then uses pattern recognition to arrive at the correct IOL power. And the latest version 3 that was published in December 2020, it gives accurate measurement for IOL powers ranging from -5 to +34. Now, the Kane formula is a theoretical formula, but it also uses artificial intelligence. Today, the two most popular formulas are the Barrett Universal 2 and Hill-RBF. And you have got an upcoming super formula that is Kane formula, and the future may be Olsen because it takes into account the entire optical aberrations of the eye. Now, the older formulas, they were based only on axial length and keratometry measurements. They were based on thin lens optics, and they fairly worked well in normal eyes, that is axial length between 22.5 and 24. But the newer formula, they take into account more measurements like anterior chamber depth, lens thickness, etc. And they are based on thick lens optics, and they use artificial intelligence and regression analysis of postoperative refractive outcome and pattern recognition. And these are useful for outliers, that is long axial and short axial length eyes. Now, Kane et al. In his review of over more than 37 studies that was conducted over more than 50,000 patients, he conducted this review to find out which is the most accurate biometer and which was the most accurate formula. And these are the formulas that were used, that is Barrett Universal 2, Hill-RBF 1 and 2, Holiday 2, Olsen, Kane, etc. The Hill-RBF version 3 was not included in this study. So they came to the conclusion that the Kane formula was the most accurate formula of all IOL formulas, and the Barrett Universal 2 and Olsen formulas, they have been shown to be the next best performing formulas. Now, the short axial length eyes pose a major challenge because a small error in the estimation of ELP will cause a major shift in the refraction because of the large power of the IOL. So if we have got only older generation formulas, we can use either Hages or Fokker-Q. But 2-3 large studies on short eyes have shown that the Kane formula was the best formula even in very short eyes. So if that is not available, we can use either Olsen, Hages or Holiday 1 or Fokker-Q. Now, coming to the long eyes, this is less of a problem because the IOL power is low here. So even in myopic eyes in this review, the Kane formula was the best formula, and this was followed by Olsen, Barrett Universal 2 and Bangkok modification of Holiday 1. Now, coming to the biometry devices they reviewed. So most of the biometers, they achieved outstanding levels of reproducibility and repeatability in spite of the difference in their mechanism of operation. And average measurements obtained were strikingly similar between the devices. And even the greatest measurement difference, they did not change the IOL power that was selected initially. So the main difference between them was their ability to measure the axial length through dense cataract, where SSOCT devices definitely scored over PCI or OLCR based devices. So the surgeon's preference may depend on other commercially available features like speed and ease of operation. Now, optimization of A constant has shown to improve the refractive outcome after surgery. Now, initially we can use the manufacturer's A constant and later we can optimize it. IOL Master 700 has got an option to do this, and latest A constants are available in direct online calculator also. We also should be aware of the potential difference between the actual and the labeled power of the intraocular lens. Now, we must have done our best, but things can go wrong. Kinshan et al. Has shown that in 17% of patients, the anterior chamber depth shifted by more than 1 millimeter from 1 to 2 months postoperatively, and this produced a change in their refraction. Now, in some cases, like PCR, we may not be able to place the lens inside the bag, and we will have to place it in the sulcus. So, in such cases, we need to reduce the power of the IOL accordingly, because the effective lens power increases as we move forward. And if you are doing an optic capture, we can use the same power IOL. Now, coming to the second eye modification, if we have a refractive surprise in the first eye, we should first check the reliability parameters. We need to repeat the biometry, and we should see whether the right IOL was implanted in the patient. If all these things are, if these things are correct, then adjusting a 50% of the first eye prediction error increases the refractive accuracy of the second eye. That is, if the first eye was left 1 diopter hypermetropic, we can aim for 0.5 diopter of myopia in the second eye. Now we need to take into account other things like what's the refractive status of the other eye, whether that eye is a high myope or not, and also you should assess what is the worst pattern of the patient. So to summarize, optical biometers should be used if this is accessible, and Subsource OCT-based devices can measure axial length even through very dense cataract. Biometry measurements need to be validated. Newer formulas like Barrett, Hill RBF, or Kane are robust throughout axial length and can be used without any adjustment. Be mindful of adjustment for sulcus implantation. Second eye refinement can further improve accuracy, and you need to do updates. Thank you.
Thank you, doctor. I have a couple of questions. One is I wanted to know, where do you access this Kane formula?
It's there as an online calculator. As far as I know, it is not available in any of the biometers, but it is there online.
Yeah. So similar to the ACRS calculator, we have it online. I just wanted to make that point. And which formula do you routinely use in all your general cases?
I always use Barrett suit. That is the Barrett Universal 2, Barrett toric calculator, and the Barrett TrueK for post-refractive. All Barrett suits.
Okay. So that also is available online?
It's available online, ACRS website, APCRS website, it is available, and the Lenstar, IOL Master, everywhere. So.
Thank you.
Yeah, Kane formula that is available online. Actually, it's an upcoming formula. The newer studies have shown that it is very accurate, and it's basically it's an theoretical formula, but uses artificial intelligence also. So it takes into account basically the axial length, keratometry, ACD, and also the gender of the patients. And then it has some artificial intelligence algorithm also. It's available only online. As far as I know, it's not available in any of the biometers. Yeah, it's good.
As per the latest literature which I read, I think Kane and Barrett 2 are more or less equivalent. Kane used to be better with keratoconic eyes, and now the Barrett TrueK is giving you the same results as the Kane for the keratoconus as well.
Barrett,
so either or is good
Barrett TrueK, I think it is for post-refractive eyes.
No, now latest one.
He has got a Barrett calculator for keratoconus eyes also
So
separately.
on our, I use the Argus. So in the Argus, if I go and press the keratoconus as the choice, as the pre-existing disease, it directly converts to a Barrett TrueK.
Yeah. Oh. Thanks.
And I wanted to know how often you calibrate your IOL master. You were mentioning about calibration of instruments, no? In routine practice, do you really calibrate the IOL master very often, or is it not required?
That is the optometrist. Actually, it's not required very often, but I think they are doing it in once in 6 months or so.
Have to clarify.
So, which are the cases you would actually consider putting in the posterior K readings in the formula, yeah.
Posterior astigmatism.
Posterior
So
astigmatism,
usually for
measured
routine
ones.
cases, we don't take it into account, but for toric IOL, definitely. But this Barrett toric calculator has got inbuilt algorithm to calculate the posterior corneal astigmatism also. So we don't have to use it separately. But that is all the more important because in case of post-refractive eyes, means unusual eyes, outliers, we definitely take. Otherwise, for normal toric also, we don't use TK, we usually use toric calculator. One important thing is, if you're using Barrett toric calculator, you should not use TK because then there will be 2 times posterior corneal astigmatism will get added up because the original toric itself has got a correction factor. Then if you're using TK, then there will be double correction.
Here I would differ a bit. Maybe in oblique astigmatisms, I would actually put in measured posterior corneal curvatures for a routine case as well.
Thank you so much, Doctor. I would now like to call upon Dr. Krishna Prasad for his talk on mix and match IOLs.
Thank you so much for the opportunity. Not, not move. No. Yes, this is my financial disclosure. So, as you all know, that natural crystalline lens has got a good accommodation, clear vision at all distance, great contrast sensitivity, no rotational asymmetry with a minimal aberration. So, my question to you all: can a intraocular lens can do the same job as the natural lens? Still, it's a question mark. So when I think we started with the multifocal, which has got a gradual diffractive steps on the intraocular lens and which creates a smooth transition between the focal points. But basically these early multifocals are nothing but it's a bifocals. So they used to have a good distance and a good near vision. People has to change their lifestyle. If they want to see near, they have to get the things near to their eyes, or they really have to change. Because of that one, the newer introduction of trifocal and EDOF lens comes into the market. So now, where is the what are the consideration for mix and match? The patient always should have a very strong desire to spectacle independent. So in my case, I picked the patient between around 35 to 75 years. But very important detailed history has to be taken. What is his jobs, and also what is his hobbies, whether he is a unusual avid reader. But for all these patients, short-term glare and halos also uh, sometimes intolerable. So counseling these patients are very important. Sometimes I feel that for them the best option is monofocal lens because uh, but if you put the monofocal lens, the patient used to come back to me and tell that, sir, I can't see the meter board while driving. So these are the problems can happen even with the multifocal lens. So nowadays most of the patient doesn't want to wear the glasses after the cataract surgery. So this is the lens I started initially. This is a Lisa platform, which is a pupil independent, which has got a diffractive ring until the IOL periphery. Basically it is a distant dominant diffractive lens, multifocal lens, which has got 65% for the far distance and light distribution 35% for the near, and with a pseudo accommodative range up to 4 diopters. So I'll not talk about this lens, just a small video. I just started implanting now. The Zeiss stopped these lenses last year, but fantastic lenses. So this was around almost my 10 years old video. I'm showing you how exactly this mix and match we used to do even that time. So the lens is basically 4 haptic lenses. So, I never had any problem with even with the rotational asymmetry. So this is the advantage with these lenses. Basically, it's a light. Why they called Lisa, because of light is distributed asymmetrically which is independent from the pupil size. The greatest feature of these lenses is with the SMP technology with the aberration correcting optimized aspheric optic. So coming to the EDOF lenses, EDOF lens is basically it is a excellent compromise benefits of both monofocal and multifocal intraocular lens, more spectacle independence compared to the monofocal intraocular lens with a fewer visual side effects compared to the multifocal intraocular lens. So basically this SMP technology is nothing but the smooth microphase technology that reduces the glare and halo. So the lens with the SMP technology normally will have a very less glare and halos. So coming to the advantage of these EDOF lenses from Zeiss is less sensitive even for the decentration and the tilt. So patient never used to give complaint if a slight tilt is there. Basically it's a neutral asphericity design lens, does not interfere with the corneal higher order aberration, and even it was suitable for post classic patient. So also lens will go through around 1.8 mm wood assisted or 2 mm with the regular injecting. The greatest feature what you can see here, even though it's a hydrophilic lens, it has got a 360-degree anti-PCO ring with a sharp edges. So these are the advantage with these lenses. This is the first. I'll not show you much about the similar kind of procedure. Basically, all these lenses, when you're putting multifocal or trifocal, your rexis has to be around 5.5 mm, so that you have to center the lens exactly, which is coincide with the coaxially sighted light reflex. This is very important. Once you do that, I think all the results is going to be ultimate with a very less glare and halos. So always you have to give the patient time about your neural adaptation also. If the neural adaptation process that take place as the brain adapt to change the visual information being supplied by the eye's optical system. So normally want to tell you the visual complaints are not related to the aberration, they are related to the neural adaptation. And the success of a patient outcome continues to improve because of they have adapted to this neural adaptation. So our experience. So it is initially for all these premium lenses, what I do normally, I myself check for the dominant eye and also I check for the which is the non-dominant eye. So once I'm really confirmed, then I ask the patient history with the dense cataract also how he used to use his eyes. For example, whatever his hobbies, how he used to do like shooting test or pointing test. Make sure that which is his dominant eye. So for dominant eye, I put the EDOF lens, and for non-dominant eye, I implanted with the multifocal lens. The inference is more than 90% of the patient at a very good distance and intermediate vision. Non-dominant eye gives you the very good added benefit of intermediate vision, and no, non-dominant eye gives a added benefit of near vision and no glare and halos in any of my patient, and they are very comfortable for night driving. The follow-up is for 6 months is going on, and extremely happy patient. Probably more longer follow-up is required. In conclusion, more than 90% of the patients are satisfied with the EDOF lens, which gives an excellent distance and intermediate vision. Adding multifocal lens to the non-dominant eye, that helps in near vision. So more than 90% of the patients are spectacally independent. Hardly any complaint of glare, halos in any of my our patient. Probably you require a long-term follow-up. So what I just want to tell, I think when you're doing any of the premium lenses, I think you have to check the dominant eye. I think that is the key. I think by putting even rings in the non-dominant eye also, the glare and halos in the eye, that patient will be much lesser. Thank you.
That was an excellent talk. My only concern is I have a few patients who go on doing this.
Yeah. Yeah, that's what I told. See, depending upon the patient, the density of the cataract. If the patient, like if you are already having a patient with cataract, even with a 6/9 vision, dominant eye, you can pick them nicely. If they are having, like for example, very thick cataract, then I won't do this mix and match things in that patient. I put a EDOF lenses. I got a different gadgets of lens. Now I just started doing excellent results. Whatever I used to do press beyond, I did a highest number of press beyond in India on the laser platform. Similar kind I am now trying with the lens, something called no financial interest, rain or EMV lenses. Excellent lenses. Dominant I put the same dead down, non-dominant I make micro monovision, and patient will get a 6/6 and N5. So can put, I'm because of the money factors, because trifocal is expensive, madam. Multifocal is very cheaper. Mm. Yeah.
What is your take on patients who would compare the vision between
Yeah,
the
my
EDOF and the trifocal or the bifocal?
actually normally my chair time with the patient for all these premium lenses is 45 minutes. I convince them after your surgery you never ever try to close each eye and do. Then you may have a slight blurred vision in your other eye. You have to be keep it in your mind. But to get you the very good vision for near vision, your distance vision in a non-dominant eye may have little bit blurred. So you never ever close your each eye. I will be keep telling every time whenever patient comes, you are not done, no, that you are not closed each eye, no, that's it. Then you are going to have a good vision. Because I used to do similar thing with the press beyond also. Patient used to come back with a very happy moments. Sir. Hmm. Yes. Yeah, Pankaj sir, the thing is, out of 100 patient, around 90 patient nowadays, they asking they don't want to wear glasses. There are some patients, they still say that I have been wearing the glasses, okay, fine, fine. In such patient, we opt for monofocal. This matter will never come in front of them.
No, in
Those,
this case, it was not the patient, it was the guard who had the problem with his glasses.
yeah, thank you. Thank you so much.
Thank you, sir, for yes.
Probably dominant eye, the trifocal might be there inside, and non-dominant eye might be having a contrast. Yeah, yeah, yeah. Even my mother 17 years before I operated with the monofocal. Then last that time other I was like never had that concept operating one day one eye next eye. Then other eye she always used to grumble with me, what you did any whenever I want to cook I cannot see for near and then for non-dominant I put her multifocal, very very happy, one eye for distance, other eye.
Yeah. Thank you
Thank you.
so much, Dr. Krishna Prasad. I can now call upon Dr. Bharati Kashyap for her talk with my experience with novel non-diffractive lead of ions. One take-home point from the previous session I would like to re-stress upon is whenever we do LASIK or multifocal, I'll always say the patient, we are going to give you binocularly glass-free vision. So never compare one eye with the other. And this, sure, yeah, we have Dr. Vikram Jain with us. Please come, sir. The, yeah. The topic is know your biometry, and I would like to know if Dr. Swati Agarwal is there in the podium. Dr. Swati Agarwal, Dr. Sean Chinkole, yeah.
Good morning.
Yes.
Can I have my slides, please? Good morning, sir. So, topic is very similar to Madam's talk. Dr. Sandhya Nair has already covered most aspects of biometry. Luckily, mine was more practical and there's not much of overlap, so that's a good thing. So, biometry, I had prepared this for a more basic level for young ophthalmologists, so let's, not many in the hall though. Biometry basically is the part where we measure various dimensions of the eye to determine the intraocular lens power that we want to implant. and to achieve a desired refractive status which may be better than before. We are already hearing about multifocal and toric, so other than reading distance, you'd want them to achieve better than before too. For this, we need a perfect biometry to start off with. So measuring the corneal curvature, keratometry, as well as the axial length of the eye. I think I'll skip these because this was a very basic one. Yeah. For axial length measurement, we can have either the traditional ultrasound methods and the optical biometers. In ultrasound biometry, what we should remember is that never applanate too much. Even a 1 millimeter of applanation can produce 2.5 diopter of error post-operatively. And it is seen that most, that is 50% of refractive surprises are related to A-scan errors. When it's an applanation done, it's related to the A-scan errors. Tips to make sure that we can get this number down is: one, calibrate your machine often, maybe once a week at least. The machine comes with a small calibration rod. You place a drop of visco or just artificial tears, put the A-scan probe over it. There'll be a value written on that rod. As long as you're getting readings which are matching with the value written on that rod, you are going to be calibrating the machine correctly. When you're looking at the scan, make sure that the echoes that you're seeing are of good amplitude. The 5 echoes that you'll be looking at is the initial spike at the appellation area, anterior lens surface, posterior lens surface from the retina, and followed by a few scleral spikes. In the leading phase of the retinal spike, there should be no rising spikes ahead of that. That would mean that there is something, either something in the vitreous itself, or you're not aligned perfectly. If it's a very dense cataract, make sure to increase your gain to the level where you're getting good spikes, but never increase gain just to make it faster, because this will lead to a lot of noise on the scan. Immersion technique is far more accurate because it does not lead to applanation. Your probe, tip of the probe is far away from the cornea, relatively far away from the cornea, but it's messy, and unless you have a separate shell for each patient which is then cleaned thoroughly, you can get multiple growths in it. It has been demonstrated. Therefore, on a single day, it is ideal to have an individual shell, which is not very practical. Few situations in high myopes, be aware of a posterior staphyloma, possibility of a posterior staphyloma, especially when the retinal spike is not end on, it will get reflected elsewhere, therefore you won't get a high spike. In post-vitrectomy cases, if it's an silicone oil filled eye, remember that this is the highest distance that the ultrasound has to traverse within the eye, therefore this matters a lot, and adjust accordingly. Use the silicone oil mode. Optical biometers are something everyone has moved on to, most people have moved on to. These are replacing ultrasound biometers for a good cause, because they are very, very accurate. The two main principles are partial coherence interferometry, as well as LCR, that is low coherence optical reflectometry. The newer one uses swept source biometry also. They have the keratometry built into them as well. The new one is the IOLMaster 700, much more accurate and much more faster, which use swept source OCT and B-scan biometry. It captures the data within seconds. 2000 scans per second are done, therefore it doesn't take even a single second to capture the axial length. The spatial resolution also for the axial length measurement is very, very low, very, very high, so 0.01 mm, and you can see everything visually. You look at this map, you will see the entire cross section, and you have the fixation check to see whether it was centered on the macula. That is very important. If the patient at that time has looked away, you will know. You have to keep a close eye on the fixation check as well as the focusing of the keratometry. So if this is well focused and the fixation check is good, centered on the fovea, then you know that it is a reliable scan and you can proceed. The fixation check, if it's not centered properly, you would lose the foveal pit there, you wouldn't see the foveal pit, so you would then redo the whole scan. This small fixation check can also help pick up abnormalities like this, especially if it was a thick posterior subcapsular cataract, you might not see a very small foveal pathology, and you can pick up all of these in the 1 mm region as well on that. It's got a very good penetration rate, 99% in these thick posterior subcapsular, which sometimes you have to use a lot of gain, and the previous generation IOL Master 500 would not penetrate. The 700 does penetrate through it, as well as in mature cataracts. To conclude, biometry is highly operator dependent. In ultrasound, make sure that applanation is not there. There are two varieties of probes. One is where the wire comes straight on and then you actually might end up pressing it. Then you have the 90-degree junction of the probe. There you can actually hold on to the optical fiber so that you're not pressing on, to make sure that you're not applanating the cornea. And in optical biometry, look at the K-map and see that it's well focused, as well as the fixation scan. To conclude, one point which madam asked that time, in the 700, actually at every startup it is auto calibrated. So if you're shutting it down during the day, every time you start up in IOL Master 700, it auto calibrates. So it's on an everyday basis, it auto calibrates. We also use the IOL Master 500, where it gives a dialog box at startup saying this was the last date it was calibrated, do you want to calibrate it again? So we calibrate the 500 every day in the morning. 700 at every startup, automatically it calibrates. It takes around 5 minutes for the calibration. Yes, thank you.
Thank you so much, Dr. Vikram.
IOL Master 700 auto calibrates. The first time the whole thing opens up, the calibration rod comes out, it does it automatically. In 500, ideally every day. It gives you the last calibration date also. I have not used it actually.
No, even in
I've
Argus,
used
it comes
Lenstar.
every
Lenstar
time.
is
So
valid
every
for a
time
week.
there's a shutdown, you have to recalibrate.
Every week.
So all the swept source machine, basically it's an inbuilt thing for it to be calibrated every time there's a restart, while the other ones, they don't depend on that for the calibration. That's a weekly calibration. Quick question.
Yes, sir.
If you have a macular edema, are you going to adjust the IOL?
Not really, because this is going to be picking up the length from the RPE.
So can you shift your spike from that area to a 200 micron area and then calculate the IOL?
I've not tried
Do
it.
you have a manual override?
I don't think so.
What is your experience on NIDEC optical biometry? Now NIDEC has come with an optical biometry. I want to know from the panel and the audience, how good is it, NIDEC?
So if you're doing a patient with a macular edema, you're going to get a hypermetropic correction. If you're going to put the IOL and then treat the patient with Ozurdex or with any treatment and the macula goes down, you're going to be left with that error.
No, sir, but in the optical, it's measured from the RPE.
Yeah.
So the macular edema won't matter. It won't matter.
Okay, yeah.
The RPE is
sorry.
imaged on optical.
My bad.
Yeah, with the ultrasound, you will be measuring from the anteretinal surface. Then it would matter.
So I just wanted to know any experience with NIDEC, because the IOL Master 700 and IOL Master 500, not everybody will be able to afford, and most of the places are still going ahead with immersion and ultrasound only still. Though we do have a role with respect to hard cataracts in immersion, I wanted to know nowadays NIDEC has come with an optical biometer. Couple of places we are working with that, so we wanted to know any specific inputs.
I've used only Lenstar and the IOL
Okay.
Master. I don't know about NIDEC. Anybody else using NIDEC?
Sure. Thank you so much, Dr. Vikram,
Thank you,
for a
ma'am.
very
Thank
nice talk. And I now call upon Dr. Bharati Kashyap for her talk on my experience with novel non-diffractive EDOF IOLs. Is Dr. Swati Agarwal here?
So good morning everyone. My topic is my experience with novel non-diffractive EDOF IOL. The need for an optical problem-free IOL was felt which has optical disturbance similar to monofocal IOL, distance intermediate, and some functional near vision. Patient can read mobile text at 66 centimeter, which can be clubbed with a monofocal lens in the eye and leads to tension-free surgeon. The need for extended range of vision IOLs were felt because presbyopia is a pain. Longer active working life is there. 60 is the new 50 or 40, and that because of diabetes, steroids, trauma, cataract is happening in younger patients. Need for intermediate vision has increased because of the invasion of devices and screens. So are trifocal IOL the panacea? No, they have loss of contrast. They're avoided in diabetic retinopathy, glaucoma, macular degeneration, post-refractive surgery, and they have photic phenomenon. So are it of the answer? Perfect answer? No. Let us see. The novel non-diffractive EDOF IOL with 6 millimeter biconvex aspheric non-diffractive wavefront shaping technology, elevation and curvature change, uses company proprietary X-wave technology. So wavefront shaping is a next generation optical principle. There are two surface transition elements that stretch and shift the light, which leads to continuous extended focal range. So there is a surface transition 1 that is which stretches the wavefront, and surface transition 2 which changes the shifts the wavefront. Monofocal IOL, you see, just focus the distance on the retina. I'm fast forwarding few slides as we have only 7 minutes. This is the transition element 1, stretches the wavefront. This is the transition element 2, which is, shifts the wavefront. So this is an example of 60-year-old guitar teacher of my son. He lives in Ranchi. He does a lot of driving. He was advised band optics, synergy, VVT, monofocal, lot of Google searching. He had unilateral hypermature cataract. I gave him option 1, driving comfortably, no visual disturbance, but using a small reading number for near. Option 2, reading comfortably without glasses, but some amount of visual disturbance while driving. He opted for option 1. So for patients looking for diffractive alternative and good intermediate function, we used to advise monofocal plus IOL, which is effective for far intermediate range, and still we use it frequently. But both the IOS, VVT and IHANS, take the sum form of the light energy from peak, that is zero defocus, and distributes it to a wider range. ICBU does it to far intermediate range, that is 1 meter distance, and VVT takes more light energy and distributes it to a wider range, that is up to 2 diopter. Remember, number of photons inside the eye is constant. Different IOS just shift the energy to different positions. We cannot have the same quality, high quality vision for distance, intermediate and near at a time. So here ICBU distributes, takes some light energy to far intermediate. Here you see DF215 VVT distributes the energy to intermediate zone, taking some of the light energy from zero defocus as compared to the monofocal. So in IHANS, if we want to achieve the vision 2 and 2.5, we have to make the non-dominating eye myopic by 1.25. It expands the effective defocus range, and same we can achieve in VVT just by making dominant eye myopic by half diopter. This was published in Eurotimes also. And the VVT contrast sensitivity is lower than the monofocal. And I'm not going to talk only good things about VVT. We must know, yes, professional drivers, night drivers, trifocal is no. For hypercritical type A personality, VVT is yes. And DF215, we have to take precaution in macular pathology, in advanced glaucoma, pterygium, corneal opacity, post-RK. Irregular astigmatism, kappa angle more than 0.6, severe dry eye, we have to exercise caution. And pupil size is very important for VVT. If the pupil size is 2 millimeter, then we have to target the take the IOL power, targeting emetropia. This is the post-op. You can see eye trace. The patient has achieved emetropia. This is the 4 millimeter pupil. We have taken the selected the IOL little myopic side. You see the post-op eye trace. The patient, we have achieved emetropia. So we conducted a study of new monofocal IOL plus ICBU with non-diffractive new EDOF IOL in our hospital DF215. The outcome measures were contrast sensitivity, uncorrected distance, intermediate and near visual acuity, defocus curve, spectacle distance, and photic phenomenon. So it was a prospective non-randomized comparative study for 20 patients, 40 eyes in each group. and we found that the distance visual acuity was comparable in both the groups. The uncorrected intermediate visual acuity and distance corrected intermediate visual acuity at 66 centimeter and 50 centimeter both were significantly better in group 2 DF215 VVT, and uncorrected near visual acuity and distance corrected near visual acuity at 40 centimeter was significantly better in group 2 group 2 DF215. So, but mesopic contrast was significantly lower in VVT. The VVT people, they don't claim this. They say the contrast is all right, but we found that mesopic contrast is significantly less as compared to the monofocal plus. So the focus curve was significantly better at 1.52 and 2.5. The proportion of patients not at all bothered by photic phenomenon was comparable in both the groups. The proportion of patients having post-op reading speed at intermediate distance was significantly better in group 2. The proportion of patients having spectacle independence in bright and dim light was also significantly better in group 2. So my take is this is a welcome addition to a spectrum of different IOL options. We can customize the surgery and visual outcomes for each patient and each individual eye by elongating the depth of field by 1.5 diopter. But there is a compromise in mesopic contrast. We have to remember that is the quality of contrast, especially at night. Good news is that there is no diffractive ring, so we avoid glare and halo that comes with diffractive technology. Ideal patients are with nice normal cornea and macula. Thank you.
Just one question. How many of your VVT patients have gone in for spectacles for near vision? You have an experience with that?
Yes.
Couple of
So
patients.
no, they say that we can operate, see mobile and everything nicely. 25-50% patients they say, 25% patients they say that just one diopter for the near. And I never tell them that you will be not needing glasses, never ever. I tell them that you can 50 centimeter distance and show in this distance you can see the mobile and you can read letters also, but if you go this reading distance then you will be needing 1.5.
Sure. Thank you so much for the nice talk.
Yes, monofocal plus and monofocal, you can, yes, you can do it. And here there is no question of dominant or non-dominant because don't know.
I invite our next speaker, Dr. Shadid Sheikh, onto the stage. He will be speaking on Carlywell IOL, a self-retaining sutureless scleral fixated IOL, a novel tool in aphakia with no capsular support. Is Dr. Swati Agarwal here? I would like to know whether the speaker is available.
Good afternoon, everybody. I'll be talking a novel tool in aphakia with no capsular support, Calver, IOL or CMT flex. As you know, the ocular trauma disease causing zonular weakness or zonular trauma after complex cataract surgery can disrupt the capsule, which makes IOL implantation in the bag very difficult. This SFIOL is one of the best option in eyes that lack both capsular as well as zonular supports. IOL haptics can be externalized and fixed with or without the use of the sutures. 22 gauge cannulas are used to create diametrically opposite ab external sclerostomies at the distance of 2 millimeters from limbus. Near each sclerostomy, 50% thickness of scleral tunnels are created parallel to the limbus. SFIL is implanted. Haptics are externalized through the sclerostomies and fed into the tunnels outside. As you know, the indications of SFILs are dislocated posterior as well as anterior chamber IOL, cataracts, subluxated, non-traumatic cataracts, aphakia, absence of zonular as well as capsular support. Ciliary sulcus, advantages of these lenses is that the ciliary sulcus is close to the focal point of the eye, separation from iris tissue, and there is a lot of distance from the endothelium. No angle or trabecular meshwork is involved. There is no distortion of pupil like iris claw lenses, no dependence on presence of iris tissue like posterior or anterior iris claw lenses. The aim of study was to evaluate the visual outcome of SFILs in patients with minimal or no capsular spot. Conducted in the Sikkim Medical College, Srinagar, from 20 to 23. So we have two types of SFILs in the market, Carvalryl as well as the CMT Flex. So we had a study of around 20 eyes. We had a pre-op vision in maximum patients of 15 in 18 by 24, and at 3 months we had the best corrected vision of 6 by 612 in 16 patients. Very least complication, just 2 vitreous hemorrhages in 2 patients, and this is the procedure which I used rather. So we, after doing peritomy at either side, that is 9 and 3 o'clock, where we are going to make 2 scleral tunnels. After doing some of the cautery, we mark the areas of where we are going to through it. We try to make 2 scleral tunnels partial thickness. We can either also have an option of making a tunnel, but the idea here is you can have a direct vision where from you can enter through the pars plana. So this is on both the sides we are making 2 tunnels, and then we can at the distance of 2 millimeters from limbus. Anyways, this is the clear corneal incision. We can make just 2 millimeters. We are introducing the cannula. These are basically angiocath cannulas which I have put in on both sides just to mark the tunnels. The IOL put through the foldable type of IOL put through the corneal incision, and it is grasped through the same opening which we had created with the cannula with the it is a grasper forceps. So same thing by handshake technique, we get it out from the other side. So it's a self-retaining type of IOL. There is no need to suture it with the sclera, except a suture is applied to the this scleral flaps. If we have made a tunnel, then there is no need of suture at all. The advantages is you can even use it in the small phaco incision. The lens doesn't have tilts like iris claw. It's a very highly stable lenses. So thank you so much. So this
Thank you. This is very similar to the scleral tuck lens which I had seen some 5-6 years back. I think that's the Parth and Rana type of lens. Is it?
I have
The
no
length.
idea about that.
Thank you so much, Doctor.
CT Flex is an Indian lens and another one is imported. I have no idea really, but it's CT Flex is freely available in India.
Okay. Thank you very much. I now call Dr. Nivian for the last talk of this session. Dr. Nivian, the talk is on yes. The talk is on complex cataract surgeries. Optimizing outcomes in complex cataract surgery by Dr. Nivian.
I loaded there.
We'll take a couple more minutes.
Is there any?
9 o'clock session. I can put directly here. Sorry, I've uploaded it. I think they're just searching for the file. So meanwhile, if there's any questions, I think, sir, it's a nice presentation. So actually, I had the one who had invented the CMT Flex IOL. So we've been having it for more than 6 years now, and it's marketed by Apasami. So it's commercially available right now. So we can. So any questions on that, I can take it just before they upload the talk.
What?
It's not a plate haptic, it's a special design which has a T-shaped haptics within it. So basically the concept is when you pull this T-shaped haptic out of the sclerostomy, it opens up and that prevents it from falling back inside. And the overall thing is 14 millimeters. You can do it on table. The only thing is you should have an AC maintainer or a trocar, because hypotony for any of the secondary IOLs is a challenge. So we have done certain scenarios on the same sitting. So most of the times it's a planned surgery, isn't it? Yeah, once you sir showed the videos, when you pull it outside, it just stays there. So other side, the handshake technique, and you pull it. So after that, you don't have to do anything because it stays there and it's positioned there. You can use glue. The beauty of this lens is because it is a thicker nodule, so there won't be any leakage compared to the other 3-piece lenses. So you can use glue, or you can just suture with the observable suture, or I just cauterize it also.
I have used this lens once. The major issue with the lens is if you put in the lens inside completely and then try to manipulate, it's difficult. If you are giving the first tag, pull it out, and then use the other to be pulled out, that becomes easier.